Thank you. So, as a neonatologist, I go to speak about oxygen. We work in Valencia with Dr. Bento, and so oxygen for us is a very huge domain of research. With the advance of novel, I make it like that. To put to pass this one.
If you use the button.
The button here, no? No, that.
Huh?
No. And here? No.
Oh.
It is like here?
Yeah.
No. Yes, no?
Oh.
Yes, okay. Like this? I think so. Yeah, I like in it. Sorry. In NICU, the extremely preterm terminal, as I said this morning, we have a lot of monitoring for preterm infant. Most of them are non-invasive, and with the critical patient, oxygen is essential for aerobic metabolism. So most of the monitoring is about oxygen. But because aerobic metabolism is the only metabolism with capable of assure the aerobic metabolism which is necessary to cellular function, to grow, and development, reproduction. No, porque están, we all know hypoxia damage, but excess of oxygen is also harmful given the immature antioxidant system in neonates. So the balance between hypoxia and hyperoxia is necessary to avoid negative consequences in immature tissues. So, here you can see how important is to balance the balance between oxygen supply and oxygen consumption, because hypoxia and hyperoxia is damage for a lot of organs in premature infants who have a lot of immature systems. But most of our patients, all of the patients have the pulse oximetry, but pulse oximetry alone lacks the sensitivity required for individualized oxygen management in NICU, because there are several limitations of pulse oximetry. It has good sensitivity to hypoxemia, but poor sensitivity below 70%. It has poor sensitivity to hyperoxemia, and it's dependent on pulse wave, temperature, perfusion, acidosis, and percentage of fetal hemoglobin, and it does not assess ventilation. Although we cannot forget that definition of the safest level of oxygen saturation remains a domain of active research in NICU. Studies show greater mortality and neurological impairment at lower saturation levels, and higher rate of DPD and retinopathy due to hyperoxia and higher levels. Here you can see the differences between three methods of monitoring oxygenation: pulse oximetry, near-infrared spectroscopy, are non-invasive light-based technology, while central venous oxygenation is invasive. Pulse oximetry and central venous oxygenation provide an assessment of oxygen supplies, while regional oximetry evaluates oxygen saturation in specific tissue regions. The correlation of near-infrared spectroscopy with central venous saturation is improved by various somatic sensors. When the oxygen delivery decrease, yeah, there are multiple mechanisms triggered to ensure aerobic metabolism, increasing tissue oxygen consumption. This increase in oxygen consumption here is slowly initially, but when it reaches a critical point here, it became exponential, leading to organ damage. Near-infrared spectroscopy represented a significant advance in personalized medicine by enabling continuous non-invasive monitoring to offer delayed insight into the balance between oxygen supply and consumption. Since our critical patients have both pulse oximetry and near-infrared spectroscopy, the extraction of oxygen from the monitored tissue can be calculated using this equation. By detecting early stage of hypoperfusion and oxygen imbalance, fractional oxygen extraction provide opportunity for intervention before irreversible damage occurs. This metric complements pulse oximetry and near-infrared spectroscopy, offering higher specificity and lower individual variability. But unfortunately, it does not appear in real time in current monitor. NIS monitor the balance between oxygen supply and uptake, detecting both hypoxia and hyperoxia. Therefore, everything that determines both the supplies and the consumption of oxygen influence the values of near-infrared spectroscopy. This slide summarizes everything that can increase or decrease cerebral oxygenation measure. Near-infrared spectroscopy there is a very more or less variability in near-infrared spectroscopy than in pulse oximetry, as you see. And there is more variability in somatic measurement. So NIRS value that must be considered as trend, and clinicians must interpret this data. Despite individual variability, each patient has their own baseline here. And when absolute NIRS value fall below 70% or decrease more than 20% of this baseline, potential cause must be ruled out. Given the many parameters that influence cerebral oxygenation measure, the algorithm of NIRS are complex. Here you have the protocol of our department when a change in 10% of the measure occurred, the clinician at the bedside of the patient decides what part of the algorithm to initiate as soon as possible to fix it. Besides, there are different NIRS devices on the market. They use similar technology, but different wavelengths, number of wavelengths, absolute value, algorithm, different algorithm, and different distance between octaves in the sensor. Most of the study has been published with involves of Medtronic, but with different sensors and with a very wide reference values. Therefore, I insist on reminding that NIRS values should be considered as trends. By optimizing monitoring, we move from a routine monitoring to proactive neurological and hemodynamic monitoring that enable us to early recognition of brain injury, facilitating timing, therapeutic intervention. In the second part of my presentation, I will present several aspects of this multimodal cerebral oxygenation monitoring with NIRS technology correlated with pulse oximetry, arterial pressure, EEG. And we are going to talk about cerebral autoregulation, which is an essential protective mechanism to maintain constant cerebral blood flow despite the changing in blood pressure. In the preterm infant, the blood pressure range at which cerebral blood flow remains relatively constant is unknown. In critical patients, we must be able to assess the state of cerebral perfusion. Of course, we can do a Doppler study, but that will be the data at this moment, and the cerebral autoregulation in critical patients change over time. Combining arterial pressure with cerebral NIRS monitoring may be a way to assess cerebral autoregulation. When there is a good correlation between cerebral oxygenation and arterial blood pressure, like in the picture on the right, autoregulation is impaired. And when there is not relationship between them, autoregulation is intact. So one of the role of the NIRS in NICU is to help us to individualize blood pressure management, because optimal mean arterial pressure did not match the 50th percentile of mean arterial pressure. That is account for changes in intracranial pressure. Hypoxia, hyperoxia, and changes in cerebral oxygenation are indirect indicators of poor cerebral autoregulation. In severe brain injury, like newborn with asphyxia and hypoxic ischemic encephalopathy, there is a severe passive state with impaired cerebral autoregulation. When we have a pressure passive state, cerebral blood flow becomes passive to arterial blood pressure change, and cerebral oximetry directly reflects changes in systemic blood pressure. In this case, cerebral NIRS autoregulation monitoring may provide an approximation for hemodynamic goal to support neurologic recovery. Here you can see the evolution of regional cerebral oxygenation saturation over the first hours and the first days of life in asphyxiated newborn treated with hypothermia, according to the development or not of later brain injury. NIRS infrared spectroscopy appears to identify asphyxiated newborn at risk of developing brain injury as early as 10 hours after the hypoxic ischemic event. When there is a persistent elevate NIRS the days after, the value of NIRS are elevated and it is maintained after this, it is associated with a normal EEG and adverse neurological outcome at 2 years. So NIRS is an important role for early outcome in predictor in this population. So far, the majority of multimodal monitoring studies are retrospective, but this one, the recent study, is the first prospective multicenter study which continued assessment of cerebral autoregulation using pressure reactivity index for individual management in infants with traumatic injury who need invasive arterial pressure and intracranial pressure monitoring. This is in infant, not in neonatal. NIRS can also be used to assess the effect of carbon dioxide in cerebral blood flow. In this study, we see how the level of exhaled carbon dioxide follow the same curve of those of cerebral autoregulation. And this is particularly true in patients without cerebral autoregulation or in case of significant hypercapnia. In this slide, we see how the routine monitoring does not alert us of danger. We have the pulse oximeter here and map the pressure here, and this does not alert us of the danger hypocapnia. The carbon dioxide exhaled in patient ventilated or NIRS in patient ventilated or not ventilated patient can warn us the secondary cerebral vasoconstriction of secondary to hypocapnia. Apnea of prematurity is one of the most frequent conditions of newborn periods. The NIRS infrared spectroscopy monitoring helps us to graduate the repercussion of these different hypoxic events. This multicenter, this study compared an episode of apnea with bradycardia to another with hypoxemia. You can see a bigger area under the curve here in the episode with hypoxemia than bradycardia. But an episode with both hypoxemia and bradycardia is worse because this has the biggest area under the curve. So in clinical practice, NIRS reveal episodes of apnea bradycardia that cause impaired cerebral autoregulation. These two records of children with apnea syndrome in our unit. As you already know, the absolute number of near-infrared spectroscopy is not significant. We must look at the stability or the instability of the train. In the patient of the left, the hypoxic events have no repercussion. The hypoxic events have no repercussion in cerebral oxygenation, but it decreases in somatic level. In the patient of the right, each episode involved a decrease in cerebral oxygenation. The therapeutic aptitude of these two children cannot be the same. Let's now see the usefulness of somatic oxygenation monitoring. The decrease of somatic oxygenation allows for early identification in systemic hypoperfusion states. Somatic needs monitoring identify early systemic hypoperfusion because it reveals change in organ perfusion related to low cardiac output and compensates shock. When cerebral oxygenation is normally preserved, it allows us a window of therapeutic opportunity to prevent organ hypoxic injury. This can be happening when arterial ducts remain open in preterm infant. More than 70% of cardiac output can shunt by the duct, producing significant systemic hypoperfusion and risk of hypoxic ischemic injury. The management of PDA in preterm infants still constitute a matter of debate. In our unit, we use also sometimes splanchnic needs in addition to echocardiography to improving clinical decision-making in hemodynamic significant PDA. In a prospective study in 72 preterm infants, we found a lower regional splanchnic oxygenation with increased oxygen extraction in hemodynamic significant PDA. There is several others news application in NICU, but I cannot have no time. But I cannot fail to mention the role of NIS and multimodal monitoring in children with congenital heart disease. This infant with congenital heart disease monitoring when we monitor the brain in this infant, it allows us to understand pathophysiology and neurological injury to achieve early detection of hypoxic insults. Since the first report of use of NIS during congenital heart disease in surgery nowadays, before the surgery in the operating theatric room and after the surgery intensive care, the use of infrared spectroscopy is that gain at the acception and in detection and guide treatment of conditions associated for acute and chronic brain injury in infants with congenital heart disease. Dr. Miller published in 2007 a study with classification and timing the brain injury seen in magnetic resonance imaging in newborn with congenital heart disease. You can see that newborn with congenital have a weaker brain abnormality even before the surgery. There are several NIS applications in cardiac surgery. It helps us to quickly evidence cerebral modulation, hypocapnia, cerebral hypoperfusion, inadequate cannular position, hypoxemia, inadequate brain temperature, ischemic safety, therefore total arrest, optimization of selective perfusion. It does not require pulsatility, advantage in cardiac surgery with circulatory arrest. It also gives inotrope therapeutic hypothermia, ECMO, and detect low postoperative cardiac outputs. So, to maintain a state of normoxia, measuring oxygen supply does not have the required precision in oxygen exposures. Going from a routine monitoring to a preventive, responsible monitoring provides us with a window of opportunity to put preventive action into practice before hypoxia and hyperoxemia organ damage. By combining pulse oximetry and neonatal spectroscopy, oxygen extraction can be calculated, providing a more detailed understanding of the balance between oxygen supply and consumption. In preterm infant, oxygen extraction monitoring gives critical intervention and improve clinical decision-making efficiency, potentially reducing the risk of both hypoxia and hyperoxia, ultimately improve neonatal outcomes. Thank you.